we can ask him. I call him the godfather of refractive surgery in India, because he was after Dr. Hardia. I think he was the pioneer in doing a lot of RKs, and then he was among the first to get the ALK, which when the first patient came to me in RP center, I said, "Ye kiya kya hai isne cornea pe?" But that's where he is. He's been really great in innovations and technology, and then Excimer also, he was the first adapter, and LASIK also. So over to Dr. Bharti.
Thank you, Maipal. Thanks to the AIOS for giving me this opportunity, and thanks Shri Ganesh. I'll be showing the new technology. So what you have heard about is the master surgeons, but what I am talking about is the fantastic machine. I'm using this system for more than 15 years, and I've been investigator for them, and now this Clear system is what is the new lenticule extraction method, which I have been investigating, doing the research, and giving them my data. And this is what I'm using for last 4 years or maybe. So Clear is clear lenticule extraction for advanced refractive correction by Zimmer, Switzerland, and of course it is flapless. The initial machine had adjustable centration. It's a very low vacuum system. It has got a guiding tunnel system for gas bubble venting, which does not allow any accumulation of gas in the central area. There are multiple incision options, one in the anterior plane and the other in the posterior plane, and there is intraoperative OCT like other machines. The beauty is the overlapping spot scan pattern, which gives absolutely no tissue adhesions, and it's a very low energy system, so there is hardly any heating or damage to the adjacent tissues. Now this is how we start. We start the vacuum here, and once the vacuum is reached, then you can center the lenticule like this. Earlier, now it is auto-centration. Auto-cyclotorsion correction was there since very beginning. You have to just mark at 180 degree, and then there are two ports. One is going into the anterior plane and the second one going into the posterior plane, and then you can go in this plane without much difficulty. You can enter, and this is the overlapping spot scan pattern, where the focus size is so small, the separation is hardly there, and there is hardly any tissue adhesions in the plane, so that it is very easy to separate. So this is like you can go into anterior and posterior plane like I explained, but later on, once you get the hang of it, then you can have one small incision of opening of 2 millimeter and go into both the planes. There is hardly any resistance to separation, and the lenticule can be pulled out very, very comfortably. So this is how you go ahead and start. And if you notice here, this is one of my first cases where I am correcting -4.5 cylinder. So astigmatism is not a matter now, and I am not using excimer laser at all for any kind of astigmatism which is there. Of course, myopic astigmatism. And here I can, depending upon what kind of incision opening we want, we can have anterior, posterior, both. And then it's the centration. Once you have docked, you put and pupil is, once you have docked, the pupil is automatically captured. There is no need to center the whole thing, and again 180 axis is marked. So there's always the axis is cyclotorsion is compensated, And then these are the two guidance tunnels. So first the posterior lenticule plane is cut with the laser. Initially this used to take 35 seconds, now it is down to 25, and very soon it will be 15 seconds for both. So it will be a matter of 15 seconds to cut the complete lenticule. This is the posterior plane, and then from here we'll start with the green color. You will see the cut in the anterior plane, and once this has done completely, then there is a post OCT. After the laser correction, there is a OCT which shows as to what is the lenticule cut, anterior, posterior, is there any issue with that or not, and this is the lenticule which you can see on the OCT. We have done with it. Now we don't need it anymore, but earlier we used to kind of use it all the time. Now I'll show you, this is when you have done the docking, and as soon as you have docked the vacuum and the machine has captured, then there is auto detection of the pupil, auto detection of the astigmatism, cyclotorsion correction, and then as I have showed you in the previous picture, there is the cut in the posterior plane followed by the cut in the anterior plane. So this is all done very quickly, as I have shown earlier, and this spot you can appreciate that there is hardly any difference in the cut. This is the OCT which is going to come. And this is the picture on the microscope, and I am capturing it from the television screen. So this is the single entry port, and here you just separate it and go into the anterior plane first completely, and then go into the posterior plane, and once you have dissected the posterior plane, you will be able to appreciate the meniscus which is there, so that you know you are going into the posterior plane. And this is the round spatula dissector, and you can see how easy it is to separate the lenticule, the anterior and the posterior planes. You see, this is very important not to separate the periphery in the lenticule, because as soon as you separate the periphery, the lenticule tends to fold upon itself. So remain in the center initially, and then once you have completely separated the center, then you separate the edge, and as soon as you separate the edge, you've seen that the lenticule starts folding upon itself, and it is very, very easy to separate the lenticule and take it out, as you can see. And here you can spread to see there is no portion of the lenticule which is left inside, because that causes a lot of inflammation as well as astigmatism. So these are the few things that we must remember. A couple of things which I want to mention here. Easier dissection causes less inflammation and nearly 6/6 vision in nearly 100% of your cases next day after 24 hours. So that is what my results are. And I have given all my data of first 200 eyes and then 400-500 eyes one by one to Zimmer to analyze. And this is the software which has come after the data given by me. And then the whole product the software was launched internationally, and now it is available. Now, after using VisuMax 500 and 800 and being investigator for VisuMax for such a long time, Shri Ganesh has also started using Z8. So that is what the Z8 is all about. And I've been using Smile in my own other center for more than 11 years. And now I've realized, and I'm using in the other center, I'm using Visumax 500. In this center, I'm using the Z8, which works very well for cataract, for keratoplasty, for flap, and for lenticule extraction. And there is no need to have a circle software because we already have the lamellar keratoplasty software, which you can use it for if there is any need to lift the flap. You can always make a lamellar keratoplasty flap thickness of 160 microns and then lift the flap and do a excimer laser correction if there is a possible, in any case you need it, though I have not had done that, but I was talking about circle software and other things, and we came to the conclusion that we can always do a lamellar cut so that we can lift the flap. There is no problem on that. So this is I think this surpasses all the current femto platforms as far as lenticule system is concerned. Thank you.
Thank you, Dr. Bharti.